Cool. Awesome. And then that way, I'm also going to make sure the transcript is going. Captions, view full transcript, save. Okay. So then now in the chat, this should work. I'm just going to give you an example. That records it in the meeting minutes, so then we can take attendance later.
Perfect. Thank you.
Welcome, Keith and Mary. We're going to get started in about 5 minutes. We're just going to give people time to show up. Usually around 5 past the hour is when we get started. Thanks again for being here, Matt. I really appreciate it.
Yeah, I'm actually moving today, so I got a little time to relax.
Oh my gosh, that's so exciting. Congrats. When do you officially start orientation?
June 16th.
Okay. Wow, that's coming right off, right
Yeah.
up here. Hey, Ranjita, thanks so much for being here. How are you?
I'm good. Yeah, I'm glad I could make it today.
Yay, that's awesome. We'll probably get started in about 4 minutes. We usually try and let folks trickle in before we start the meeting.
Yeah, of course.
I'm trying to get away from the stereo.
All right, everyone. Hello. Can you hear me okay? Yes. Okay, awesome. I'm Jess Pelletier. I see a lot of familiar names and faces today. I am the African Medical Coordinator for Techies Without Borders, and I want to thank you so much for coming to our CMES Journal Club. As a little bit of background information, we have a couple members of our team here, Ranjita Raghavan and Matt Piechnik, who are going to be helping with the session today. Ranjita can answer any questions you have in the chat. So feel free to chime in on the chat if you don't feel comfortable answering questions out loud, or if your connection is not good. So again, feel free to put questions and comments in the chat. And then Matt will be asking people to introduce themselves in the chat so we can get a sense of where people are joining us from today. As some more background, the Continuing Medical Education Solutions Program is a technology-based program designed to improve access to continuing education and to build a culture of continuing education in the areas that we serve. We work with 19 low and middle income countries. This journal club is specifically for our partners in Africa, and we try to kind of tailor the content to your context. And we look forward to learning from you as we go through the topics today. Again, feel free to type questions in the chat. We're going to talk today about alternative routes of medication administration. And I'm going to be asking for some volunteer participation and involvement. We'll start off with some cases, and then we'll go through routes of medication administration in terms of their pros and cons. We'll do a deep dive on the rectal route and then go through some MacGyver moves. I know that's an American term, but what it means is some tips and tricks. And then we'll do a wrap up at the end. So we'll start off with why we are talking about this topic. We always pick our topics for these journal clubs based on the most recent content from Emergency Medicine Reviews and Perspectives, also known as MRAP, and emdocs.net. So we pick one topic based on the content that is uploaded to our system. For those of you who have a CMES Pi or USB, this episode came out in April and is accessible on your apps or on your USBs. And so it's a funny title, but it is a very interesting episode that sparked our interest in discussing this today. And our journal club board voted for this topic. You can message me directly if you are interested in being on the journal club board that picks these topics each month. All right, let's go through some cases. So our first case is a 3-year-old female coming to your accident and emergency unit with vomiting and diarrhea for 24 hours. She can't keep anything down. And on exam, she is sleepy, tachycardic, has dry mucous membranes, skin tenting, and her capillary refill is 3 to 4 seconds. She's too sleepy to drink, and your team can't get an IV. My question to you is, how would you address this at your hospital? How would you try and rehydrate this kid since she can't drink? Feel free to chime in out loud or in the chat. I see Mary wrote intraosseous. I think that's a great idea. Venous cut down. I will be honest, I've never done that in the clinical setting, but that's awesome that you guys are trained and know how to do that in a sense. Anyone else with different approaches? NG2, nice. The question I have for those of you who wrote intraosseous or NG tube, do you use any medications to facilitate the patient tolerating that? I know in my experience, when I've tried to put an NG tube in a 3-year-old, they just pull it right back out, even if they were sleepy to start off. And intraosseous lines can certainly be painful, even if you use local anesthetics for insertion. Nasser says no medications. And we heard Caroline said NG tube as well. So it sounds like NG tube is a popular answer, and I think it's a great answer. I would love to hear in the chat if folks can chime in how they usually get people to tolerate NG tubes, because they're pretty uncomfortable. I know in my setting, we often will use topical lidocaine jelly to facilitate putting it in, but the keeping it in is the challenging part with kids who don't understand why they're getting an NG tube. Ranjita, I'd love to hear what your approach would be to this patient in your setting. So you've got all the resources available to you. How would you approach rehydrating this kiddo?
Yeah, no, I mean, obviously it's very tough with the kids. I think with this, I mean, all those ones are pretty good options. I feel like with an ultrasound guided line, we still would probably be able to get a line, and we could use some medication to calm her down. So that was easier. Yeah, I wouldn't even, some of those other things that we would do, even if I feel like I would use some sort of procedural sedation if I was going to use one of those techniques. If it needs to be done faster, I think the thing that I'm most comfortable with would be doing the ultrasound line, and then hydrating her with IV, versus if we do need to do something more invasive like the IO or something like that, then once again, I think it's going to be necessary to give sedation or something like that first.
Yeah, no, I think that's probably a similar approach to what I would use with the resources I have available to me. Is anyone else using ultrasound guided intravenous line placement in their shop? I know Nazar said that kids are usually forced to tolerate the NG tube in her setting. And I am curious to hear how people get the kids to keep the NG tubes in. Because that's a challenge that I've certainly had. Anyone else using ultrasound IV? You can feel free to chime in the chat. I'm going to move on to the second case. All right. So in case 2, you've got a 24-year-old male with cannabinoid hyperemesis syndrome. For those who don't know what this is or who aren't familiar, this is actually becoming quite a problem where we work in North America. And I'd love to hear if folks have seen this in Africa at all. But for people who chronically use marijuana products, they can end up getting a terrible chronic vomiting disorder called CHS. And it can persist even after they quit using marijuana. I know in some settings, this is called like hashish or hash. So different names for the same thing. But in any event, this patient who with a lot of vomiting comes in for another episode of intractable vomiting, and he comes with a bucket and fills it twice in the waiting room before he comes back to see you. He's tachycardic with dry mucous membranes, but he has no skin tenting and normal capillary refill. So a little bit less dehydrated than our previous case. However, he can't stop vomiting long enough to take an oral antiemetic, and he does not want an IV because he comes to the hospital a lot and he's sick of getting poked. How would you approach this case at your hospital? How would you go about rehydrating this patient? One option I would consider for this guy might be doing a rectal antiemetic if he's willing to. Dominic says, how can he not want an IV? That's a great question. I think in our setting sometimes for Ranjita and I, which is terrible, we often see people who come to the emergency room an awful lot. And so they often don't have a lot of venous access left because either their veins are so scarred or perhaps if they're an intravenous drug user, their veins are very scarred. Other problem is that they get superficial venous thrombosis from getting so many IVs. So sometimes there just aren't a lot of veins left, and we end up doing things like external jugular veins, in rare cases having to put in central lines if people really need medications. I wonder how you guys would approach this patient. Oh, good. Someone said promethazine. Yeah, that's what I was thinking. Something that you can give rectally as well. Other options. Reassure him that the IV line will be of great benefit to him. I like that answer. Verbal redirection. That is certainly an option to consider. And then you might have to get a little creative if he doesn't have any IV access left, depending on how scarred his veins are. Good. Okay, let's move on to case 3. This is our last one to just get the ball rolling with our discussion. You've got a 75-year-old female on palliative chemotherapy for metastatic cancer, and she's coming in with intractable nausea and vomiting for 4 days. On exam, she's cachectic and chronically ill appearing. Her vital signs are actually normal, but she has dry mucous membranes, skin tenting, and her capillary refill is 3 to 4 seconds. How would you approach this patient? And it looks like some other people added in suggestions on the previous patient. Intramuscular antiemetic. I love that idea. Mary, if you wouldn't mind telling us which intramuscular antiemetic is kind of your go-to or your first line in your setting, I think that would be a good learning opportunity for everyone. Other thoughts besides intramuscular antiemetics for this particular patient who's very dehydrated, and she's on palliative care. So this is a little bit of a different situation. She's at the end of her life. Mary said on Danzatron for intramuscular antiemetic. I think that's a great choice for the previous patient or for this one. How would folks go about rehydrating this particular woman who's on palliative care? We're actually going to talk about some creative methods for rehydrating patients in this situation, especially folks who don't want an IV line. So we'll get to that later on during the talk today. If you think of other ideas that you would use at your shop, please feel free to chime in the chat. We're going to move forward and go through some different methods of medication administration, and I will be looking for some interactivity here. What do people see as the pros and cons of oral medication administration? What are the good things and the not so good things about that particular route? Feel free to chime in out loud or in the chat. I know for me, convenience would be the most obvious pro, but there are certainly a lot of cons too. Anyone?
I mean, I agree with you. That's like convenient, but then sometimes it's hard to get the right amount of fluid that you need for a patient. And if a patient's really sick, they're not going to be able to take a lot of oral. So that's kind of the con. But then obviously the pros are also, if they are really awake, you know, when you're drinking it yourself, you're not going to overdo it and have some of the electrolyte or abnormalities that you might have when you were just pumping fluid into somebody and they are not regulating it through their GI system and all of those things. So
yeah, those are great points, Ranjita, especially when we're talking specifically about fluids. I know many of you only have normal saline available in your settings. Some of you, I'm sure, also have lactated ringers. Feel free to chime in the chat about which IV fluids you have. But when we give fluids via the intravenous route, you can certainly get a hyperchloremic metabolic acidosis from giving too much normal saline. And so oral rehydration, that's not going to be an issue. But if you are too nauseated to drink, then obviously that you're not going to be able to take things by the oral route. The other concept that we'll get to in a little more detail in a second is first pass metabolism. And then not all drugs are going to absorb equally. And then if people have issues with their gut, so let's say they have short gut syndrome because of prior surgeries, or they have some severe inflammatory bowel disease, or some other reason that they're not absorbing medications well due to inflammation, then not all of the medications you give orally may be doing the job. People who can't swallow, so maybe they've just had a stroke or they have end stage dementia, things like that, might prohibit people from taking oral medications. And then I know gastric irritation is a big problem for us, especially with doxycycline, which we use pretty frequently in our setting for skin infections and for lots of other stuff like tick-borne illnesses. There are tons of other medications that are irritating to the intestines, like, in our setting, it would be ibuprofen, but NSAIDs, non-steroidal anti-inflammatory drugs, things like that. Feel free to chime in on any other oral medication pros and cons that we might have missed. But moving to what first pass metabolism is, I'm sure most of you are familiar with this, but a lot of the gut blood supply drains through the liver. And so the liver ends up metabolizing anywhere from 0 to 100% of a medication. So the amount that the liver takes out or makes unusable by the body is going to vary from drug to drug. But this is an important point for some of the other methods of drug administration we're going to discuss, because you can bypass this first pass effect or this liver removal of medications because of the oral situation. Innocent just said bitter taste. Yeah, that's a really good point. Some meds taste terrible, and that's especially a problem for children. For those of you who work with pediatric patients, they do not like the taste of stuff. And then taking multiple medications, no one thinks that's fun, of course. And so swallowing handfuls of pills can be a big challenge for patients, especially with compliance. Thank you, Innocent. That's a really good point there. So we talked about the oral route. Let's go through some pros and cons of the intravenous or IV route of medication administration. Anyone, feel free to chime in out loud or in the chat. What are some challenges and also good things about the IV route? Convenience would definitely be a pro if you're able to get IV access, but I think for most of us, giving IV meds is probably more expensive and requires more resources. Yeah, infections is a con. So I think what you're probably referring to, Nazra, and correct me if I'm wrong, but obviously if someone has skin infection, like they have cellulitis, or they have inflammation like a superficial venous thrombosis, or a DVT in their upper extremity, we're not going to be able to give medications this route. So that's going to be prohibitive. So let's move to some of the pros and cons I had written down here for IV. Quick onset and then avoidance of first pass metabolism are big pros for IV. So you go around the liver basically, and you don't lose any of the medication you're administering. Pain, I think, is less of an issue for adults, but for children, it's definitely a problem. In my setting, we'll often use topical anesthetics or cold packs, things like that, before we put an IV in, because kids poorly tolerate this situation. Feel free to chime in the chat if there are other strategies or methods you use to help people tolerate the pain of IV placement. Distraction is definitely a good one too. They've done some research here in terms of using virtual reality, basically just using a phone to get people to tolerate IV placement better. All right, and then moving on to the transdermal route. Again, feel free to chime in the chat if you can think of any pros or cons of the transdermal route. Things I came up with, there's not a lot of medications that actually are available via the transdermal route. And then there's also a slow onset for transdermal medications. The pro is that you can use extended release formula. So things like fentanyl patch can provide longer acting pain control. And it's pretty easy for patients to do this themselves at home. So it's easier for them to give their own medications. Moving on to inhaled meds. Can anyone think of some pros or cons of this route? This is the list that I came up with. So fast onset and again, avoidance of first pass metabolism. But the con with inhaled meds is they might need a spacer, which I know isn't available everywhere. Innocent said causes nasal irritation. Totally agree. Here we were specifically talking about orally inhaled medications, but depending on how irritating the medicine is, it can also cause nasal irritation. Yep, short acting. Dominic, thank you. Only 10 to 40% of drug reaches the lungs when we inhale medications through the mouth. And so not a lot of it is getting to where it needs to be. And then variable absorption. So thinking about with the inhaled route, you've got all those little cilia and things like that. You've got lots of systems for clearing things and preventing them from getting to the lungs, which is a protective method for the immune system, but it also creates a disadvantage for inhaled medications. And then there aren't a ton of systemically available drugs that we can give in this formulation. A lot of the medications that we give via the inhaled route are just being given for respiratory purposes. Okay. Next, we're going to have transmucosal routes. So we'll go through intranasal, oral transmucosal, vaginal, and rectal routes. Intranasal route, I know that Innocent already mentioned nasal irritation. Another challenge with this is limited fluid volume, meaning you can't give necessarily as much medication as you may want to. And then this can have variable absorption because, again, you have cilia and immune system processes in the nasal passages that are designed to protect the body from bacteria and other pathogens. The pros, though, are very fast onset because you have great blood supply to the inside of the nose. Non-invasive approach, and then it avoids first pass metabolism similar to the IV route and the inhaled route. And you can give direct administration of CNS medication, so central nervous system. One thing I didn't mention, but intranasal is a problem if someone has a cold or some sort of upper respiratory infection, because if you're congested, then the medication's just not going to get to where it needs to be. So that can be a pain. Moving to the buccal route. Feel free to chime in the chat if you can think of any pros or cons for this route of medication administration. But depending on how quickly the medication dissolves, someone might have to be able to hold it in their cheek on the inside for quite a while. And if someone can't follow directions, that can certainly be challenging. This is a choking hazard for little kids if it's not something that dissolves quickly. And if someone's vomiting actively, then you can't really use a buccal medication. Because of the limited absorption capacity for the buccal route, there's a limited dose and volume. And the pros, however, are that this is fast onset. And like the other forms of transmucosal medication administration, this generally avoids first pass metabolism. And you can do it even if folks can't swallow well. There are also sustained release medications for the buccal route. And yeah, thank you. I appreciate your response, Nasanga. You said limited to adults and older children. So little people definitely can't follow these instructions to keep medications in the inside of their cheek. So not realistic for small children. Okay, moving to sublingual, some of the same issues. You have to follow directions. These do usually absorb a little bit faster, and there is more absorptive space for the sublingual route than the buccal route, but same pros as with the buccal route. Quick onset, avoidance of first pass metabolism, and then people with dysphagia can also use this. Okay, and then we're moving to vaginal. Pros and cons, feel free to put them in the chat, but you can use sustained release medications and patients can give them at home. Obviously, the con is that this is pretty uncomfortable and there might be personal or cultural barriers to having healthcare workers administer medications vaginally. And there just aren't a lot of medications available in the vaginal route that are systemic medications. There's plenty of things like hormonal therapies that are available in the vaginal route. And then the last route of administration we'll cover is the rectal route, which I think is a little bit underutilized. It does provide 50% avoidance of first pass metabolism because there are different sections of veins surrounding the rectum. So half of those veins bypass the liver and the other half go through the liver. And so this gives you a little bit less systemic absorption than the other transmucosal routes of administration, but there's a wide variety of drugs that are available rectally. And so you can use this for both local and systemic drugs. Patients can give these medications at home. And if you have access to a rectal catheter in your setting, you can give these medicines over a long period of time. Rectal catheters that are specifically designed for the rectum can actually stay in place up to 28 days. I am curious how many people have access to rectal catheters in their settings. This is not terribly common for me to see in the ER, in the emergency department or accident and emergency. I'm going to type that in the chat as well. So the cons obviously is that, again, there are personal and cultural barriers to having people administer medications rectally, and it's pretty uncomfortable. Not all medications can be given rectally, and some can be irritating to the rectum. And you certainly can't give this if the rectum's full of stool, or someone's having active diarrhea, they have rectal bleeding, or they've just had some kind of bowel surgery. So at this point, we've gone through all the major routes of medication administration. Feel free to chime in the chat if there are any routes of administration used at your hospital that I did not talk about. But at this point, we're going to move on to a deep dive on the rectal route, since the MRAP episode that this session is based on provided some additional details about rectal medication administration that I actually learned. So this is a list of some pretty common medications that many of us use in our settings that can be given rectally. I actually had no idea that a lot of antibiotics, antipsychotics, or ibuprofen, which is a NSAID, a non-steroidal anti-inflammatory drug. A lot of these meds I did not know that you could give rectally. And of course, you always need to check with a pharmacist before giving a rectal medication to ensure that the formula you're using is safe to be given rectally. Oh, Gmo, thank you for typing in the chat, intrathecal. I didn't get into that mainly because we do not use that in the accident and emergency setting, and we're kind of focusing on emergent medication administration here today. But intrathecal is a super important route of medication administration for chemotherapy. I am curious if you're using that route for anything else besides treating cancer. So other than chemotherapy, are you using this like for cryptococcal infections, or are you using this for something else? Feel free to answer out loud or in the chat. All right, and I'll move on from here. So continuing talking about rectal meds, drugs you definitely cannot give rectally. We need to be aware that extended release formulas are just not going to work when we give them in the rectum, right? Because they are designed to be broken down in the gastric system. They're designed to be broken down by gastric acid, and they're specifically timed to release when they get to the right place for absorption. Some medications are irritating to the rectal mucosa, so we certainly would not want to give things like doxycycline or potassium via the rectal route. And medications that have poor bioavailability in general are not going to be well tolerated or very effective, rather, via the rectal route. Finally, drugs that have a narrow therapeutic window are definitely not safe to give rectally. So colchicine was one I definitely thought of. I guess digoxin would be another example. So things with a narrow window of safety would not be safe rectally. There are a few more comments in the chat. Analgesic sprays can be given topically. Yeah, thank you, Mary. The topical route is really great. And we only talked about fentanyl patches and those sorts of things. But sprays and creams and gels are also super helpful, especially analgesics for like home treatment of pain. And again, using topical anesthetics, I think, can be a great way to prepare people before you do minor procedures, like putting in an IV in a kid or doing an incision and drainage in the emergency setting, if you have access to that. Nasaga mentioned rectal diclofenac, and yes, NSAIDs like ibuprofen and diclofenac, most of them can be given via the rectal route, which is super awesome. Dominic chimed in that another route of medication administration we didn't talk about would be intra-articular. And yes, that typically we're only giving intra-articular medication specifically for that one joint. You can't give systemic medications via the intra-articular route, but that is one we did not mention today. So thank you very much. And intraosseous, I kind of lump in with intravenous because most of the same medications can be given via the intraosseous route that can be given intravenously. It's a great route of medication administration. It's cheap, easy to access. On the note of intraosseous medication, I would love to hear in the chat if people have access to intraosseous needle insertion devices like IO guns or the Easy IO, or if you're typically just putting in an 18 gauge or a 16 gauge needle into the bone. So how do you typically administer intraosseous medications? I think that just gives us a sense of what resources people have available. I know in my setting, we have an IO gun. So it's like a drill and you just press a button and it goes right into the bone. But I'm curious to hear what other people do. Moving back to the rectal route here. So if you're, again, unsure about whether a medication is safe to give rectally, please make sure you check with a pharmacist and look it up. Don't just give any medication rectally. But I think this is a great alternative route if someone cannot take oral medications or you're having a hard time with an IV, or if they're refusing an IO, that sort of stuff. So how to actually give oral tablets rectally, assuming it's a safe medication. This was some interesting stuff in the podcast I mentioned at the beginning. So an oral tablet can actually be crushed and reconstituted in 10 cc's of water. It's recommended that we don't use more than 20 cc's because it's just going to leak back out of the anus. So a lot of the medicine isn't going to get to where it needs to be. So no more than 20 cc's of water. And then you can just use an angiocath, so the plastic part of an IV needle. So no sharps, don't put any sharps into the rectum, but using the plastic angiocath that would typically go in someone's arm for an IV is a great way to go ahead and inject that crushed tablet that's reconstituted in water into the rectum. I did not know that you could do rehydration via the rectal route. So if someone's incredibly dehydrated and you really can't give them anything orally or via the IV, perhaps you don't have an NG tube, you can actually give fluids via the rectal route, but you have to be very careful not to give hypertonic fluids. So I would never give something like normal saline via the rectal route because that's actually just going to draw water into the rectum and make the person more dehydrated. Remember that the rectum's typical role is removing water from stool and making it harder and making it into a solid. And so anything hypertonic, so anything more dense, is going to pull water out of the system and make the patient more dehydrated. So again, only hypotonic fluids if you have to rehydrate someone rectally. Before we move on to some interesting sort of MacGyver moves or tips and tricks for medication administration via non-typical routes, I did want to mention Mary put in the chat syringe needle for intraosseous insertion. So it sounds like you're just putting an IV needle and using a syringe directly in the bone for an IO. Is anyone else doing something else in terms of getting intraosseous access? Do you use a manual screw device? Do you have a drill, or are you typically using a syringe and a needle method? And Mary, I am curious how you stabilize it. Someone else just asked a great question. Won't the angiocatheter cause trauma to the rectal mucosa? That is a great point, Nazareth. So if you are going to do the rectal route, make sure, first of all, that it is allowed via your hospital policy. And so we're talking like a probably 18 gauge angiocath, just the plastic. I would probably put some lubricant on it and just insert very gently using your finger. You definitely want to make sure you're not perforating or puncturing anything. Do not put any sharps near the anus or the rectum, but gentle insertion of the plastic piece just so that you can administer the medication using your finger and using lubricant can be a safe method as long as it is approved by your hospital policy. Let's go through some MacGyver moves, some tips and tricks for medication administration. The first one I wanted to talk about is hypodermoclysis. Is anyone using this in their setting? Feel free to chime in the chat. I'm gonna have to make sure you can see my screen. One moment, there's an advertisement here. Are you able to see my video screen or are you seeing my PowerPoint?
I think it's still well, I think it might be the video. I mean, it says the hypodermis insertion and care.
Hold on, let me try something else. Can you see the video?
Yes.
Okay, can you hear it?
No.
No. Okay. Well, in that case, I'm going to scroll through the video and I will make these links accessible to everyone later. But hypodermoclysis refers to subcutaneous medication administration. And this is a great option for people who cannot tolerate oral intake or for whom you cannot get an IV. And so this woman is showing that essentially ideal spot for this would be the upper shoulder and right near the scapula. So she's gesticulating here to the upper scapula area. And you want to consider using this method for very old and frail patients who have loose skin where fluid can fit underneath the skin. You should never give more than 1 liter in a particular area. And there are limitations on the flow rates, which I'll send in the post-journal club summary information. So you can't give this very quickly. Things you would need, this has to be sterile. So you need to clean the skin using an alcohol swab or chlorhexidine. And then you need to make sure that you have a tiny butterfly needle available in order to insert the fluid. And then you're going to keep that in place using something like a Tegaderm or another stabilizing device. Again, I'll send the link out to this video, but essentially she shows you how you would insert the butterfly under the skin. And she goes through, let me pull this up here so you can see it. You want to make sure that you're not inserting it into a blood vessel. So basically what she does is she pinches the skin and makes sure that she's inserting just into the subcutaneous area. So you're going very superficial here. And then she's going to leave it in place. You have to have a pretty slow drip rate with this. So again, I'll send out that information with the journal club summary. Another interesting way to consider giving medications would be via the inhaled route. And we talked about that earlier. Not all medications are available systemically via the inhaled route. I'm going to pull up another video so you can see how to make a spacer out of a plastic water bottle. And again, I would love to hear if people are using these methods like subcutaneous hypodermoclysis or whether they are making their own spacers in their setting. Let me try and share my screen with you guys again here for the water bottle spacer method. I am sorry, I don't know how to make the sound come through, but again, I am going to send these links out too. Is everyone able to see the video of the gentleman using a water bottle to make the spacer? So he's cutting the top off of a water bottle. He is putting an inhaler on the end of the bottle. And then there's a mouthpiece basically by slicing off the other end of the water bottle. So pretty easy to do, very cheap intervention. All of us, I'm sure, have some plastic water bottles laying around. And if you don't have access to a formal spacer, that can be a great option. He's going to show you how to actually do it on a patient. So this kiddo. They're having a hard time getting the kid to follow directions, which is typical even with any regular old spacer. But you can see that it would function similar to a formal spacer device. So this is a great option if you're in a limited resource setting. One other alternative method of medication administration to consider that I'm going to pull up here, and I'll show you the video, would be making your own atomizer. So we talked about the transnasal route of medication administration. Let me try sharing my screen with you. So there are some medications that are absorbed systemically via the intranasal route, and one of those would be something like ketamine. Other options to think about, stuff like Versed or other benzodiazepines can be absorbed via the intranasal route. If you do not have an atomizer at your hospital, you can make your own, and I'll send these links out. They're all on YouTube. But Jess Mason goes through in the video how to make a atomizer yourself. So she's taking a nebulizer chamber, which in the chat, if you can chime in whether you have access to a nebulizer chamber in your setting. But essentially, she's going to hook this up to the medication she wants to administer. So I'll send these links out so that you can actually hear what she's saying in the video, but I think it's pretty interesting to know that you don't have to have a formal nebulizer, or rather a formal atomizer device, in order to administer medications via the transnasal route, because those can be pretty expensive. If you're not familiar with an atomizer, it's essentially a tiny piece of foam that connects onto the end of a syringe. You push through it hard and it makes tiny particles out of a medication so that you can give it through the nose easily. All right, I'm going to share my screen again. This last one is a little bit controversial, so definitely make sure that you're not violating any hospital policies by using this method. But if you have a patient who needs like a large volume of some sort of transrectal medication, so for example, they need to get a large volume enema, and they just simply can't hold the material inside their bottom, or they're having a hard time getting a medication in themselves at home, you can technically use a Foley catheter, very well lubricated, and just use that to insert a medication. It needs to be taken out right away. You cannot leave a Foley catheter in place the way you would with a rectal catheter. So again, lubricate well, don't force anything, insert slowly into the rectum. Check with your nursing protocols to make sure you're allowed to use this device to give a rectal medication before you do so. But essentially you inflate the balloon and then you just gently tug until the balloon is sitting against the rectum. You insert the medication through the flush port, and then you use a 3-way stopcock or clamp on the catheter to keep the medication from coming back out. So again, this is a nice option for patients who can't hold an enema inside their rectum. Maybe they have poor rectal tone or something like that, which we see commonly with very old adults, the elderly population. And again, do not ever leave a Foley catheter in place in the rectum. It is not designed for that. This is a rectal catheter, which can be left in the rectum for up to 28 days. Typically, it's for patients who are on palliative care, who are in their final stages of life, for giving things like pain medicines if they cannot swallow and stuff like that. A Foley catheter is not designed to stay in the rectum for any period of time. It is not technically designed for rectal administration, but it's an off-label use to just insert medication, but do not ever leave a Foley catheter in place in the rectum. It can cause pretty bad irritation of the mucosa if you leave it in place. Always document what route of medication administration you use. If you're giving something via an off-label route, so if you're giving an oral tablet via the rectal route, make sure that you document that in the patient's chart and describe how you gave it. And again, always check with your pharmacist if you have one available, or check your medication referencing guides to ensure that something can be absorbed and given safely via the rectum if you're going to do that. So just to wrap up, there are lots of ways to give drugs for patients who can't swallow or who have difficult IV access. I really appreciate so many of you chiming in the chat about the creative ways that you've found to give medicines in your setting. Consider the rectal route if you haven't in the past, and then use the tools you have available to you and follow hospital policies and protocols. Definitely always check with your pharmacist or local guidelines before you give oral drugs via the rectum. These are my references. I want to thank you guys so much for coming today. I am going to leave up the QR code to the survey for just a couple minutes here, and I will stay on for any questions that people have. I'm going to put the link to the survey in the chat. If you would be so kind as to fill that out so we know how we can make these sessions more helpful for you in the future, we'd be appreciative.
Jess, I wanted to ask because, you know, I was thinking about the subcutaneous delivery for the fluid.
Yeah.
And I did remember, because I was thinking about it, that one of my colleagues actually used that for a kid who was dehydrated, where they were having a hard time with the IVs and all of those as well. But did you see anything specifically that shouldn't be children, or?
Great question. No, I did actually see some case reports and things like that out there that hypodermoclysis or subcutaneous IV fluid rehydration can be very useful for kids and for very old adults. Obviously, someone needs to have like somewhat loose skin so it can stretch. And so older people are going to be more likely to have that loose skin. But you can certainly do subcutaneous fluid administration in children as well.
Yeah, okay, cool. Yeah, no, yeah, because I think I had a colleague who just did a little bit. They did that a little bit just to get the veins enough that they could then get the IV. But you're right, it'd be easier in someone with more space. Yeah.
Yeah. I'm going to put this in the chat too. Is anyone else using subcutaneous fluid rehydration, or hypodermoclysis is the fancy name for that? I know the few times that I've had IV fluids sort of extravasate or kind of come out of an IV, I've been like, well, I guess we're going to get subcutaneous absorption, so it's okay. They'll still get some of it in there. It's just going to take a lot longer. Awesome. Well, again, I'll stay on for a few minutes. Thank you guys very much for attending today. I really appreciate all of your engagement and folks responding in the chat to questions. And if you have any specific questions for me after the session, you can feel free to email me, which I'm putting in the chat, or you can send me a WhatsApp message. We send out all of the videos and then the journal club summaries via WhatsApp. The slides will be accessible to you, and they have the links to the videos I mentioned as well. Thanks again, Matt and Ranjita, for your help today.
Thanks for a great presentation. Thanks, everybody.
Thanks, everyone.
Take care, all. Thank you. See you next month.